Another category is the SNRIs, and instead of selectively leaving behind just serotonin, this one also adjusts the amount of norepinephrine. It keeps the brain from sucking both serotonin and norepinephrine back up, and that increases both neurotransmitters being available to those postsynaptic receptors to help control mood. Getting rid of serotonin in the body can have a lot of devastating effects emotionally. Some years back, there was a brand new blood pressure medication that controlled the amount of norepinephrine. And that makes sense because norepinephrine, when introduced into the body, is going to constrict blood vessels, and that's going to make the blood pressure go up. So people started noticing there were these fantastic improvements in blood pressure, but unfortunately, suicide risk rose in people taking this particular drug. And when they investigated, they realized that it was because of a shortage of norepinephrine. So it's more than just a sympathetic catecholamine, it also helps control mood. These particular drugs can do the same thing that the SSRIs can do. Nausea and a loss of appetite. The mouth can feel real dry, so we want to encourage our patients to get plenty of fluids and maybe keep some hard candies in their mouth for when they complain of feeling dry. Some people report being real tired and sleepy. And of course, the sexual side effects. It can slow down sexual reaction and inhibit sexual climax. Some people find that their nose may bleed. They could have some GI bleeding and some liver damage. That's pretty rare, but those are possible adverse effects that we see. Anything that affects the amount of serotonin or norepinephrine can cause a bad drug interaction. One of these is St. John's wort, which we've talked about, because that causes a natural rise in serotonin, and that increases the risk of serotonin syndrome. Some things that people should remember when it comes to both SSRIs and SNRIs is that we need to screen for suicide risk. A lot of people believe that talking about suicide might give a depressed person ideas, but that has not been shown to be the case. If somebody is depressed, whether short-term or long-term, believe me, they have thought about suicide at one time or another, even if it's just a fleeting thought. It's not going to be a completely foreign concept to them, and you're not going to increase the risk. One important thing to remember for these drugs is do not discontinue suddenly. Because they can take several weeks for the drug to take effect, abruptly stopping it is going to kind of throw the brain into turmoil. And somebody who's been on it a long, long time can really cause themselves to have some bad signs and symptoms from stopping abruptly. They need to be weaned. Ideally, they should seek a doctor's assistance in weaning, but if they don't want to deal with that, they should gradually cut their dosage down, maybe switch into every other day and then maybe every couple of days and then gradually decrease. If possible, a person should not be encouraged to just take medication alone. They need therapy and things to help them with the depression and anxiety, and we can refer them to other community agencies that might help with this, particularly if they do not have insurance that will help them to get into a psychiatrist or a therapist. On page 201 in the book, we see patient and family teaching that deals with depression and these SRIs and SNRIs that take care of that. The next category is a category called the TCAs, or tricyclic antidepressants. These are older. They tend to have more side effects, but they still have been shown to be pretty effective in certain cases. They are also believed to keep the brain from the reuptake of norepinephrine. and or could be both, serotonin. They help with endogenous depression. That's depression that comes from inside the person, a shortage of the proper neurotransmitters. And it can help with mild depression due to exogenous causes or things that happen from outside. Job loss, loss of a relationship, death in the family, just the general stress and tension that we have every day. Sometimes the TCAs have been found to be effective in the short term. Of course, we've got side effects that you can expect, and some of these are similar to the SSRIs: dry mouth, sleepiness, some GI problems such as constipation, orthostatic hypotension. That's always a risk, especially for the elderly. In severe cases of adverse reaction, you can have cardiac dysrhythmias and heart failure. They can also lead to seizures and weight gain. So this drug is going to be contraindicated in somebody with any kind of cardiac illness. Drug interactions, you see there's quite a few, and most of these are central nervous system depressants because the tricyclic antidepressants have been caused to cause marked drowsiness. The prototype tricyclic antidepressant is a drug called amitriptyline or Elavil. It's an older antidepressant, first used in the 1950s. There are more side and adverse effects than SSRIs and SNRIs, so they mostly now just try to limit these to people who haven't responded to other antidepressants. So you won't see this taken for just straight depression the way you used to. In the ATI book, TCAs are discussed on pages 53 and 54, and we see it covered in the textbook on page 202. And then we have our big table of medications on pages 198 and 199, and tricyclic antidepressants are discussed on page 199. These drugs can be especially toxic with overdose. When it was found that patients would overdose in a suicide attempt, many times they were successful because it causes cardiac problems. Now with rapid discovery and ICU treatment, sometimes these patients can be saved, but it used to be considered a pretty fatal overdose. So you're not going to want a patient who's had a recent MI or has any problems with their liver and kidneys to take tricyclic antidepressants. They also don't want to see it used in narrow angle glaucoma because of the effect of these neurotransmitters on the fluid in the eyes. When you see Elavil used now, it's mostly used for chronic pain. They use it for fibromyalgia. They use it for neuropathy from diabetes and other causes, and they use it in smaller doses. Whereas they used to use 75 to 150 milligrams for depression, now you're going to see 12.5 to 25 milligrams used for chronic pain, and it's got a pretty strong sedating effect. People are encouraged to take these at night. Make sure you read Patient and Family Teaching on page 201.